Part 1 of the substance use disorder videos, and we are going to hit on the high-yield facts about downers for the exam. So it is crucial that you understand what withdrawal looks like and what intoxication looks like for every substance because this is commonly tested on exams. The key for withdrawal is that it is the opposite of whatever intoxication is. So say you have an upper such as cocaine, withdrawal is going to look like a downer. You're going to be more lethargic, more depressed. Likewise, if you have a downer such as alcohol, withdrawal is going to look like upper symptoms such as agitation, high blood pressure, tachycardia. Always remember that lethal withdrawal is with booze, barbs, and benzos. Those are the 3 substances we really worry about withdrawal with because you can die from them. Now, alcohol is going to be the most commonly tested substance, and that is because it is legal, lots of people use it, and withdrawal from it can be deadly. The mechanism of action is it does activate GABA, dopamine and serotonin, and it inhibits glutamate. Symptoms include disinhibition, slurred speech, ataxia, mood lability. Just think of a drunk person. That's what intoxication looks like. BAL correlations, 100 to 150, there's going to be the ataxic gait, poor balance. 300, they're going to go into a coma if they're not super used to alcohol. And then 400 is respiratory, depression, and death. Intoxication can be deadly as well as withdrawal. Of note, if you have someone that comes in and their blood alcohol level is like 200 something, they're walkie-talkie, that means that they drink a lot at baseline and they've built up a tolerance. So how do we treat acute alcohol intoxication? Your priorities are going to be your ABCs: airway, breathing, circulation. You want to stabilize the vitals, you want to protect from respiratory depression because alcohol is a CNS depressant. In addition, and examiners will test on this, you want to give B1, thiamine, and that is to prevent Wernicke's encephalopathy. After you give the B1, then you can give glucose and folates. High yield, thiamine must be given before glucose. And this is because glucose actually uses up thiamine, so it can actually precipitate the Wernicke's in depleted patients. So alcohol withdrawal is incredibly high yield on exams. It will almost always show up on the exam and you need to know it like the back of your hand. So the mechanism is cessation of that depressant. It's going to lead to the CNS hyperactivity to compensate. And that's going to be that glutamate excitotoxicity. Again, the opposite of intoxication is withdrawal. So because alcohol is a downer, you're going to see more upper, more excitatory symptoms of that withdrawal. So in the first 6 to 24 hours, you're going to see mild symptoms. That's going to be anxiety, irritability, insomnia, tremor. But then you get into the danger period, and that is the 12 to 48 hours when they can have seizures. Now, they can have seizures at any time, but this is the most dangerous time for seizures. You also worry about the 48 to 96 hours. In the 48 to 96 hours, you worry about delirium tremens, which is also commonly tested. Now, in delirium tremens, there is altered mental status, there's hallucinations, there's autonomic instability, fever, tachycardia, high blood pressure. Delirium tremens can be deadly. This is why it's so important that we recognize it and treat it right away. So how do we treat the alcohol withdrawal? Benzodiazepines. Now, in real life, we use other things such as phenobarbital. We can sometimes use gabapentin. But for the exam, benzodiazepines are the answer. They are first-line therapy, and we can use the CWA protocol in order to know when to give benzos. We can also give it on a fixed schedule if we're really worried about DTs or seizures occurring. Say a person has a history of complicated withdrawals. We want to treat them with aggressive hydration, correct fluid electrolyte imbalances. We want to give that thiamine. We want to give folate. And we need to monitor them closely and put them in the ICU if we're really, really worried about withdrawals. Continuing to monitor those vitals. Again, DTs can have tachycardia. It can have hypertension. So if you start to see those numbers increase, you start really worrying about DTs. Now, you will be tested on medications used in alcohol use disorder. First line for alcohol use disorder is naltrexone. This is an opioid receptor antagonist that reduces the desires or cravings for alcohol. Naltrexone is great. It's once a day or once a month if you use the IM version. It can precipitate opioid withdrawal, so you always want to ask your patients about opioid use before giving naltrexone. And it can also affect the liver. So if your patient has severe cirrhosis, you might want to use a different medication. Now, acamprosate is also first line. It's used for relapse prevention. It's thought to modulate the glutamate transmission. And it's great to use in patients with liver disease, but it's contraindicated in those with renal disease. So you have a patient that has renal disease, then you want to use naltrexone. If they had liver disease, you want to use acamprosate. In real life, acamprosate is very difficult because it is a 3 times a day medication. Now, second-line agents. Disulfiram, antabuse. This drug blocks aldehyde dehydrogenase, and it causes adverse reactions like flushing, nausea, palpitations if the patient drinks alcohol. It's a really nasty medication because it has such a bad effect, and it's not just if they're drinking alcohol. It's if they touch alcohol, if they use hand sanitizer. There's so many things that can cause that sickness, like it's just not a great medication to use, but it will be tested on your exams. Topiramate can also be used. It's an anticonvulsant that reduces cravings by potentating GABA and inhibiting glutamate receptors. And then gabapentin, also great. It can be used to improve sleep, reduce anxiety, reduce cravings. It's also used in very mild alcohol withdrawal. So all these medications can be used, but the ones that you really want to be on the lookout for in exams are the naltrexone, acamprosate, and disulfiram. Now that we've talked about alcohol, we're going to talk about its lookalikes, benzos and barbiturates. Now, benzodiazepines potentate GABA by increasing the frequency of chloride channel opening. Remember that, they increase frequency. Whereas barbiturates increase the duration of the channel opening. Remember this because they like to test on benzos increasing frequency, whereas barbiturates increase duration. Now, they have the same withdrawal symptoms as alcohol. That's why it can be deadly to withdraw from either benzos or barbiturates, because you can also go into DTs with these medications as well. Alcohol acts on GABA, which is why benzos and barbiturates can be used to treat alcohol withdrawal. Now, these medications can also have all the same symptoms as alcohol as far as intoxication. So they can have drowsiness, confusion, slurred speech, ataxia, hypotension. Severe toxicity can cause respiratory depression and coma, especially with barbiturates, which you're more likely to overdose on barbiturates. And the risk escalates significantly if they're ingested with alcohol or opioids, basically any other CNS depressant. Synergistic effects can lead to fatal CNS depression. Always check for multiple substances because sometimes exams will test for those. So if someone overdoses on benzos or barbiturates, the treatment is going to be supportive care. Just like with alcohol intoxication, we monitor the ABCs, but you might get tested on flumazenil. Flumazenil can be used to reverse benzodiazepines. They reverse the sedation from them, but we rarely ever use this. And this is because they can precipitate seizures, and we don't want to cause seizures in the patient. So that's why we tend to use supportive care instead of this reversal agent. Next, we have opioids, which are commonly prescribed for pain. Common examples are heroin, oxycodone, morphine, methadone, fentanyl, meperidine. Their mechanism of action is to stimulate the mu, kappa, and delta opioid receptors. Now, they work on the reward pathway. They directly affect the dopamine system, and that drives the reinforcement and addiction potential. They are central nervous depressants, so they can cause death and overdose. Now you have to know opioid intoxication for the exam. The overdose triad is respiratory depression, slow, shallow breaths, decreased breaths, altered mental status, stupor, coma, and then meiosis, which is very classic for opioid overdose. You'll see that the patient has pinpoint pupils. Now, the one exception to this is meperidine, which typically causes mydriasis, but it's very rare that they're actually going to test on that. They'll typically present the patient with pinpoint pupils. You also have to know how to treat opioid overdose because it is a medical emergency. Prioritize the ABCs just like all the other CNS depressants And then you want to administer naloxone. Naloxone will always be the answer. It can either go IV, IM, or intranasal. And rapid recovery often happens once the naloxone is given. So what does opioid withdrawal look like? It's going to look like the opposite of intoxication. So there's going to be piloerection, goosebumps, yawning, rhinorrhea, lacrimation. GI distress, there's going to be vomiting and diarrhea. Intoxication of opioids can cause constipation, so it's not surprising that diarrhea would be a withdrawal symptom. There also can be dysphoria, anxiety, insomnia, intense cravings, and muscle aches, bone pain. They're going to feel like they're dying, but they're not going to die. It's very uncomfortable, but not life-threatening. So we're more worried about opioid intoxication versus opioid withdrawal. Now, you might get questions on how we treat opioid use disorder. And there's 3 main medications. One is methadone, which is a long-acting full agonist. It's commonly tested on exams. There's another, which is buprenorphine, which is a partial agonist, and it is safer. There's less risk respiratory depression with that medication. And there's naltrexone. So naltrexone is actually an antagonist, and it precipitates withdrawal if used within the past 7 days. So you definitely want to ask your patient if they have used opioids recently, because it may cause a really nasty withdrawal if you give it and they've just taken an opioid. For symptomatic support, especially with opioid withdrawal, clonidine can be used to help with symptoms, and then NSAIDs can be used for pain. For more high-yield videos, click on the right. Otherwise, good luck on your exam.